Good afternoon, everyone, and welcome to Caring Conversations for End of Life Care. My name is Ayana Woods. I'm the Executive Director of End of Life Choices New York, and I'll let my colleagues introduce themselves.
I'm Monica Coleman, and I'm a mental health counselor licensed in Mississippi and a consultant with 6Dimensions in Mississippi.
Good afternoon. I'm Nikitra Burris, the owner of 6Dimensions. We are a research development and practice company based in Mississippi.
Thank you. So I'm going to start off and talk a little bit about my organization, End of Life Choices New York. End of Life Choices New York seeks to expand choice at the end of life, respecting every individual's wishes and striving for the best possible quality of life and peaceful death. And we provide education to communities, health professionals, we offer counseling services and advocate for legislation to improve patient rights. And we believe it's every patient's right to determine their own end of life care. And while different communities may have different ways of handling death and grief that may affect their end of life choices, patients' core wishes tend to be universal. So at the end of life, we would all like to avoid pain, maintain dignity, be with loved ones, and have our individual wishes and beliefs honored. And so I'm so happy to present at this year's conference because end-of-life care is not often included in conferences like this one related to health education and public health. But end-of-life care is a very complex issue immersed in an ineffective and complicated and unprepared healthcare system. And unfortunately, a society very uncomfortable with discussing death. But as the baby boomers continue to age, and the growing ranks of the elderly and those approaching the end of life, how seriously ill people are cared for must be reformed. And so we need to think about interventions to disrupt the type of end of life care where patients risk ineffective treatments, frequent trips to the emergency department, inadequate system management, and insufficient time to plan for their care with their loved ones. So look at this stat here. New York currently has the lowest rate of hospice utilization in the country, and sometimes it flip-flops between 49th and 50th. But what a horrible statistic for New York, a state that's considered to be an innovator in healthcare. In New York State, unfortunately, many people die protracted deaths with terrible suffering. In 2015, there was a report called Dying in America by the Institute of Medicine, and it showed that people consistently died badly and often ways inconsistent with their wishes. Many people also receive care at the end of their lives that they do not want or would not want if they were fully informed of their treatment options. And patients are not informed about palliative care and hospice, or referred so close to death that hospice could only provide minimal benefits. So why is that? And also, I just wanted to note, some people might not know what hospice is, so it's important to define that. So hospice is a type of care. It's not based in a location, it's a philosophy of care, where people who have been diagnosed with 6 months or less to live can get a whole host of treatment options by an interdisciplinary team composed of a physician, nurse, social worker, bereavement counselors, chaplains, religious leaders to support not only the patient and the family. And so, as I mentioned, I think it's just so important to talk about end-of-life care and to really understand some of the disparities in access to care. And so the objectives of this session will be to describe common language and preferred terminology regarding death and dying among Black New York communities, identify barriers to end-of-life conversations, planning, and care experienced by Black New Yorkers, examine focus groups as a method to inform program development to improve healthcare equity at the end of life, and promote health literacy in end-of-life focused programs. So inequities in end-of-life care, it's a big problem, and it's been further exacerbated by the negative impact of COVID. Even looking at pre-COVID, only approximately 30% of adults have advanced directives in place to ensure that their healthcare wishes would be known if they became too ill to communicate their own wishes. And of course, COVID really highlighted our issues with end-of-life care, made people reflect on the mortality, and just they said, just highlighted a lot of problems with the system. And so, unfortunately, people of color are less likely to have an appointed healthcare agent or have had conversations about end-of-life wishes. Black Americans are also 75% less likely to have completed an advanced directive, and these inequities persist even when adjusting for other factors such as religious affiliation and educational attainment. Doctors are also less likely to provide adequate pain management to their patients of color. And we've seen this with the studies that say residents think Black skin is thicker or Black people can tolerate more pain. And Black and Latinx and Asian patients have lower rates of hospice enrollment and spend more time in the ICU while receiving more aggressive end-of-life care. Even while Black patients have DNR orders in place, they are more likely to receive life-prolonging treatments, such as mechanical ventilation, meaning that their end-of-life wishes are not being respected. And so clearly, there's a critical need to raise awareness and educate New Yorkers on their end-of-life options. And while information about advanced directives and palliative care and hospice care is available, that information is out there. It's clear that this information is not reaching a sizable portion of adults in this country. And additionally, information might not prompt action. As the source of information may be considered distant or unrelatable to a person, these communities of color have warranted mistrust of the medical care system. It's plagued by systemic racism, bias, culturally incongruent care, and other challenges. So it's hard to talk to someone about what to do when you're dying, when you're having this kind of complex and complicated relationship and history of oppression with the medical care system. And so, as I mentioned, studies have shown that Black and Brown patients suffer significant inequalities when facing their deaths, but this information comes from hospice data and Medicaid data. There's relatively sparse information on how Black New Yorkers and their self-identified end-of-life care needs from their own voices and from their own experiences. And so to ensure that all New Yorkers can have the end-of-life care they desire, we realize the need to foster and facilitate open dialogue and create solutions that are community-driven. And we decided to do this with focus groups. So we wrote a grant and received funding to host 2 focus groups. They were for people who were healthcare providers who identified as Black and who work with families to engage and work with families at the end of life. And we asked them to engage in a community conversation with us around the end-of-life care needs of Black New Yorkers. And we also asked them to pass this information along to any colleagues who they believed could add value to the conversation. And also the staff at End-of-Life Choices New York recruited participants a variety of ways through emails, social media, primarily LinkedIn and Instagram, and direct contact with partners we had, like other nonprofit organizations that we've been working with. And so the data was transcribed using in vivo transcription, and the common themes were extracted from each segment of the discussion. So some of the specific focus areas for the sessions included experiences and perceptions, end-of-life conversations among Black New Yorkers, common language, and education and direct services and advocacy. So who is in these focus groups? We conducted 2 focus groups with 4 participants in each. 63% of the participants represented the public sector in the careers serving Black New Yorkers. And so looking at these different groups, we see faith community. We had a chaplain who spoke about their experiences. The private sector included an elder care attorney and someone who helped with patient navigation and insurance. We had a nurse practitioner who also provided her thoughts, someone who worked for a senior center, a social worker, and a professor in academia. So the results from this, we found out a lot and we learned a lot, and we're excited to share that with you today. All participants expressed that systemic factors impact the care that Black New Yorkers receive. Participants that represented the private for-profit sector and healthcare explicitly identified the systemic barriers within the healthcare and legal systems impact on end-of-life care. And so we know that there are challenges in terms of the legal aspect of end-of-life, that's completing a healthcare proxy form, living wills, guardianships, and not all of us clearly have access to the legal guidance to help with that. We also know that the healthcare system is a beast, and accessing hospice and palliative care and specialists and understanding our prognosis is quite the challenge. And then with caregivers need a specific role in end-of-life care and planning with their loved one. data has shown that caregivers are not fully prepared for their role in the medical decisions at the onset. Usually these caregivers are thrusted into being a point person for care, participating in appointments and coordinating care across specialists and responding to emergencies. But this may change with people involved and who's there and who's available. And it gets complicated. Sometimes families feel that even acknowledgement of an illness may somehow speed up the dying process. So they don't even want to discuss it. And there's a lack of knowledge around prognosis oftentimes amongst the family, understanding the various stages of a disease, trying to navigate all the medical options available. And sometimes caregivers are unsure about having someone like a visitor's nurse come and play the role that maybe families have traditionally played when we're looking at Black families who rely on collective decision-making and their family-oriented care. And so there might be confusion or uncertainty about hospice and other long-term care options. And then we want to make it clear that end-of-life care is a social justice issue. Looking at some of the quotes from the participants, one said, I think that's part of the struggle. When we talk about equity and social justice, is who can pay, get the service, they get the access, they get to know about hospice. Another one said, when is the role of individuals' primary care or their physicians, as well as their healthcare system, to ensure that these things are not in the 12th hour, but they're actually established early in the relationship with the physician? And in New York and across the country, doctors often refer patients who have maybe 1 or 2 weeks less to live. And so the benefits of hospice that it can provide and how it can manage pain and provide psychological support, the family's not even getting that. Another participant said, death is very much a social justice issue because we look at our hospitals, we look at the doctors, we look at the fact that most insurance companies don't even tell us about hospice care until it's too late. And we just look at all the layers of trauma and grief that we're dealing with collectively and personally. It's a wonder that any of us even get up and make it through the day, quite honestly, and we deserve people who understand that to help us. And then there were also quotes about removing the concept of fighting. I think that's a huge issue, not with only in the Black community, but generally speaking. When someone is dealing with an illness, we use the term fighting cancer, battling cancer, lost their battle with cancer. And one of the participants said, I also really feel like, especially for Black New Yorkers, we go through so much of our lives fighting so many different systems of repression, so many levels. I would really love for us to take the fighting aspect out of the dying process, at least for people who that it doesn't feel good to. I would also say, another person said, I would also say the first thing that comes to mind for me is just the words of like battle and fighting, which is not particular to Black New Yorkers. I think it's something that we definitely hear a lot, which sort of feeds into this concept of just like a person who has died as a result of the loss of a battle. And it makes me think of the movie The Color Purple, when the character Sophia, played by Oprah, says, I had to fight. All my life, I had to fight. And it's even in a Kendrick Lamar song that people like to reference. It's this idea that Black people and BIPOC folks are always having to fight. And I think it's really important to kind of remove that language and what the participants were saying, to remove that language, because when you think about resiliency, when you think about BIPOC communities, generations of trauma, systemic racism, and cultural barriers have led to this fight to be resilient. And it's kind of very different when you look at these communities and the notions of resiliency and battling. And this should be considered, and we should consider the impact it can have. And so when discussing resilience, we must acknowledge and center the narratives and history of the BIPOC community. And it's critical to understand this. And so we have to be careful about language and how we tell BIPOC communities to be resilient, how we tell them to fight, especially with end of the life, because it's not creating an opportunity for comfort care.
Thank you, Ayana. I think this is such an important point here that you're bringing up around language. And of course, I'm going to dive a little bit deeper into it. Two things that really stood out to us. One was all of the participants, every single one of them across both groups, found that language, identifying acceptable language, is challenging. And so there's sort of this conversation that we're trying to have, but we haven't had the conversation. And so it's hard to know where to start. It's hard to know what to say to even get it going. And then figuring out what words to use really depends on culture, depends on religion, it depends on spirituality, and a whole host of factors. And even within a particular culture, we see subcultures. In our group, we had all African American people of color, but we had people that were from different cultures within Black culture. And some of them used different types of language when they talked about death and they talked about dying. And so understanding what words to use, what language, what terminology really depends on who you're talking to, and we were able to find that out through our two groups. So one of the things that we looked at was what's acceptable then and what's not acceptable when we're talking about common language around death and dying. And so we found some terms like getting your house in order and saying that someone passed or passed away or they're going home or they are going. That was kind of acceptable. Whereas transition was one of those words that really depended on who you were talking to, which culture you were in. For some people, it worked, depending on your profession, depending on the group you were talking to. But then for others, it was kind of cold and it wasn't welcoming. And then there were some terms that we also saw that were totally unacceptable. Terms like committed suicide, which in the mental health profession, we've long done away with that terminology. But even in this community of Black New Yorkers, we found that that was some terminology that they had also found to be inappropriate or unacceptable. Drank the Kool-Aid, meet their maker, got snuffed, which is a term that we often see in the media when we're looking at violence, gun violence and different things like that, murder, referring to murder. And so these were all terms, though, that in this community, they were saying, this is not how people want to talk about it. When you hear someone say these terms, it's offensive. And so you think about what is media saying about how we talk about death in Black communities and specifically in Black New York communities where, like Ayanna mentioned earlier, this is one of our biggest cities in our country. We look at this city for how we approach different things in culture, in the media, and even in what we see in the media. Our group is identifying and saying, this is not really how we do it. This is not really acceptable for us, even though we see in movies and in pop culture time and time again, some of these terms. So when we think about the experiences and the perceptions with the people that were in our groups, there were some mixed things that we saw here. So about half of our participants talked to us about how end-of-life care and planning depends on the type of death or the ailment that a person experiences. So for example, if the person had an unexpected death, then the way that we talked about things looked different than if the person was ill or had cancer, for example, or if the person, even depending on the type of illness that they had also dictated how those conversations went. There are some illnesses we know and that were brought up that they don't want to talk about them at all. And so they definitely don't want to talk about end of life care and planning. 6 or 75% of our participants also talked about end of life care as an issue of humanity and humanness. And this perhaps was to me, as I facilitated both of these groups, this was probably the piece for me that stood out the most to inform how we can take this work and advance in this area, because even though we had professionals, a lot of them brought their own humanness into our focus groups, and they talk from a very personal standpoint, as well as speaking from how they provide services. And there were a lot of just humanness on display, emotions, crying, and just encouraging one another, and just kind of assuring one another that this work is a process. It's not a one and done thing. And we do this work with our whole self, with our whole being. And so we can't compartmentalize how we have these conversations with individuals. And we have to take care of ourselves as we do the work. These were some of the things that really kind of were salient for me as I facilitated. I could really feel that sort of genuineness, that authenticity among the participants, that above all else, we are working with people. And death is something that impacts all people. And so we have to show up as human beings when we're doing this work. And then overall, and all of our participants, definitely this came out among all of them, that overall Black New Yorkers do not properly prepare for end of life care. And as a reminder, Ayana mentioned that in our group, we did have people that specifically prepared DNRs and power of attorneys and different types of legal documents, that was their role in the community to do that. And we had chaplains and healthcare providers and people in the academy, but all of them agreed that this is something that's not being done well or not happening among Black New Yorkers. And so this definitely substantiates the needs for an organization like Ayana's, but not just in New York. We anticipate that this is probably happening beyond New York. So in terms of these conversations and how we go about having them, 75% of our participants talked about this need for completeness of documentation and how it depends on the access to the appropriate professionals. And so just like in any other service, whether it's mental health or healthcare provider, whatever the service is, people tend to like to do business with people that look like them or people that give them some sense of familiarity, and there's research on that. And so a part of finding the appropriate professional looks at what is the pool of professionals that are available to me and whether these professionals look like me, whether they sort of make me feel safe, make me feel comfortable talking to them. But I think the first issue really is just, are they available? And it's particularly here with this point, we looked at families not having access to legal professionals. So think about the pool of attorneys out there or paralegal professionals out there who may be able to support, and whether or not these individuals have access to them. Finances is also one of the barriers here. Also, participants representing the private, and I sort of just spoke to this, talked about people that work in the private sector. There were two of them, and they talked about this uphill battle for people to access the appropriate professional. Again, that's financial barriers, and then just people that look like them. And they're, just being honest here, this is a business too, right? So people get paid to do these type of things as well, and so finances really can matter here when it comes to making sure that people have access. Another thing here, acceptance and understanding of death makes it easy for a person to initiate the conversation. So here, about half of the participants discussed that if a person was more accepting, more understanding of the topic even, then it made them more comfortable initiating a conversation around it. But remember in the beginning when I said, like, we're not having these conversations to begin with. And so, it's really hard to get these conversations started because there's a lack of common language. There's so many barriers. And then when we look at the end of life conversations and how they're being either avoided or they're happening when it's too late, every one of our participants basically echoed this statement that the people that they're serving, and these are people primarily that served, I think it was close to 60 or 70% of Black New Yorkers, or 60 or 70% were represented through our population here. They're basically saying here that we don't have people that are having these conversations with us. They're either avoiding them or we're having the conversations, but it's after someone has already passed away. And at that point, are we really honoring what that person wanted? Because we really didn't get their wishes to begin with. So it's kind of too late. So we also asked about, what type of information can we provide to support your education. This is education to the providers and, even to the community. And then what type of direct support are they providing as well? And so trust became an important issue here. It was an emergent theme when we looked at the second focus group. These were people who talked about trust being important as they provided strategies to build trust among the people that they serve. And so when we talked about trust, one of the key things that came out from that is that it takes time. And so if you're approaching a family and you're trying to have this conversation off the bat, that's not really a good strategy because you first need some trust there. And so building trust, making those connections over time seems to be the best strategy to even get to the point where you're talking about end of life choices and end of life care. But then support is needed for professionals as well. So the same people who are trying to help the families need support too, so that they can be effective to provide these services. And all of our participants express a need for additional resources for themselves to be able to better support. We even saw among them that, in addition to just training and resources, there was also this need for self-care among them as well. So here's some list of training things that we saw kind of raised to the top in our data among our 8 participants. So one is legal documentation. So not everyone that participated in our group knew how to create and prepare the legal documentation that families would need. Things like power of attorney, DNRs, do not resuscitate orders, things of that nature. So some of them, even though they work in this area, had not had training on how to complete this paperwork. Also, a series on health and wellness was an idea that came up because the idea was that maybe we can't invite people in to talk about end of life care, but if we talk to them about health and wellness, that gives us a natural sort of platform to talk about end of life care without being so out front about it, because we know this is a population that, again, either avoids the conversation or, waits and talks about it until like at the point that it's too late. Also initiating the conversations with families. So we had stories about, how people would talk about this and certain people in the family didn't want to talk. And so they would avoid things or get angry even sometimes when someone would bring up certain topics related to end of life care. And so just training for them on how to initiate these conversations with family was something that they wanted. And also training around coping with death and planning for those left behind. So, when a person passes, their family and the people that care about them are still there. And how do they cope? How do they continue on and honor that person's life? Also, we know that, as Ayanna has mentioned, this is a social justice issue and there are rights related to this issue. And oftentimes people do not understand them or know what they are. And so that's another area of training that our group brought up that could be useful. Some other areas, financial planning, I've already talked about that, just the barriers around that, but also cultural humility and carrying out cultural traditions. And so, again, thinking about that common language and what media might be saying is okay, may not necessarily be representative or honoring the culture that we're serving. And so practicing this work with humility and carrying out the traditions of a particular culture is important. Also, we saw a need to focus on queer health and also just end of life decision making. So what models are out there and how can our providers use those when they're talking to families? So some additional considerations here. So respect for feelings when providing end of life services. As I mentioned, a lot of the time that we spent with our participants was very human-like. And so our providers feel that it's so important, and we agree that when you're working with people to talk about end of life services, that you really do respect their feelings around it. And this was very significant among the first group where we did have one participant who was very tearful throughout the focus group and shared a lot of personal things that they went through as they were helping families that were going through this as well. Respect for diversity and spirituality and culture is also important here, and things that we should consider. This came up in both groups, and how value and culture just really plays a role in the end of life planning. You know, there's this ideal of what we as professionals think should happen, but then there's this culture humility that we can practice, where we allow to happen whatever is the wish of the families and the person who's going through this situation. And we really want to empower. That's one of the goals of social justice, and liberation is another. And the only way we can do that is by understanding what people wish and what they want, and then building a plan to respect that. And then end of life care services, they are valuable, and we know this. And there's all sorts of, Ayana mentioned all sorts of reports out there looking at insurance data and things of that nature that show us that this is something financially that we should look at. But this is also valuable because these are people, right? And as we think about, you know, healthcare and how we serve people, and even the literacy of people, this is one of the areas that we really should center, because it's something that we know impacts everyone. So this is work that is valuable. In terms of our group dynamics, we just want to sort of point out here again that we had people from both the public and the private sector. And we recommend that if you're going to, you know, be engaging with the public and private sector, there are some strategies that we should consider. And so with the public sector, it's important for them to sort of center on their profession and the values of their profession. Self-care strategies as they do the work to support themselves. As I mentioned, some of them, all of them were professionals, but they also brought a lot of their personal self into the work, because this is very personal work. It impacts all of us. Also, just service tend to be a core value. And so you'll see in this work that this is sort of something that people feel they're called to do this work. And so it becomes really core to them. And then process-oriented outcomes tend to be a strategy that we see could be useful in the public sector. Whereas in the private sector, we think that looking at systems and being process oriented as well could be more aligned with this sector, but also creating a direct pathway to look at the return on investment, because systems tend to look at the ROI at the end of the day. And then using strategies that show the value, as I just mentioned, about the end of life planning and how that impacts organizations and systems and structures, but including strategies that engage families through their humanness. So I even think about grassroots and how they can impact the private sector and helping them see the value, because, you know, at the end of the day, people do have power when we work together.
Thank you, Ayana and Monica, for just kind of providing the backdrop of how these conversations came about, how they started, and how we progressed through them. So you've heard Ayana talk about the mission of End of Life Choices New York, why this work is a social justice issue, and how we went about getting information on how to just have conversations in community. And so as we completed the focus groups, we really tried to take the recommendations and look at them from a public health kind of perspective with the social ecological model. So I'll talk a little bit about how we, some of the recommendations for this work moving forward. So we looked at things from every level of this model. So first, the individual level, how one of the big things is making sure we elevate the experiences of Black New Yorkers. And so that was central to Ayana and her staff's theme as we came on board, really giving the community a voice. And so even in recruitment, we thought about how could we bring every voice into the room, those direct service providers and those lived experiences. And it was such a great experience to have everyone, all of those same people in the room that kind of serve dual roles. Ayana, I'm gonna let you pick up for just a second while I grab the school bus.
Sure. And talking about amplifying and elevating all voices, I just wanted to touch on something that Monica had said in terms of that these people were in the community and serving the community. And particularly one of the participants, he refers to himself as Mr. Elder Care. So his identity is being an elder care attorney. And in the end of life doula, that work, and she was also a grief therapist, is so entrenched in personal experience. So not only were they sharing it from a professional perspective, but very personal. And I think that kind of plays into some of the points that Nikisha was making in this slide as well. But in terms of, and also to the point of elevating the experiences of Black New Yorkers, as I said, that those voices are lost, they're not included. The traditional end-of-life care movement has been a very white, rich movement and hasn't considered the lack of access that other individuals have, and even this notion of unwanted medical care that's often used instead of wanted medical care. It's coming from a place of privilege. So I think it was so important for us to hear people talk about things from their own unique experiences, both being providers and Black New Yorkers as well.
Thank you, Ayanna. Thank you. So, and just picking back up from where you left off, Ayanna, even though these support models, so thinking about that community support, this was a very communal group, even though they represented so many different sectors, but that support among the group was important. But it was also important as they translated that out into community. And so when thinking about having these conversations, one of the groups was, well, one of the individuals in the group worked with different support groups. And so they felt it was really important to equip even the group members, the community members, with this information to serve as peer support. And so maybe that, though that was a very informal way of discussing it, one of the areas of opportunity here is to create these really peer-to-peer support models that really give people leverage to have the conversations in a way that is supportive and in their peer groups. And then training caregivers as advocates. Ayanna talked a little bit about the role of caregivers, but as we went through the groups, it was the caregivers often struggled to find their role. And so caregivers often, they went all the way in for their family members, but what about their own health? And so part of it was trying to really train those caregivers in those advocate roles to not make decisions for their family members, but to really guide the family member through those decisions. Because I mean, even we know that when we work with our family, we get very emotional when it comes to family. And so we think we know what the best route is for that family member. But if caregivers have a very distinct and defined role and they're trained in that, then they can better help guide their family members to the experience that they desire. And then individual organizations providing emotional support for service providers. Monica mentioned how this was a very big issue of humanity and humanness, and every participant, whether they were from the public or private sector, brought themselves to this conversation. And they talked about how taxing this was. And even when Ayanna talked about the social justice, when she read those quotes, it made me continue to think about that emotional support that these providers needed. It's a heavy load to lift, thinking about death and dying and end-of-life care, because of how we framed it, not only as a country, but also just in the types of experiences that Black Americans have. And so that emotional support for those providers, such as chaplains, even those in serving in the private sector. I mean, everyone spoke with so much emotion that there is a self-care component to it. And then organizational policy, offering end-of-life planning, making that available to employees so that those conversations are normalized from when you become an employee all throughout your employment, to creating those policies. And when we think about equity and social justice and who deserves to die with dignity, everyone deserves that. And so as workplaces take on policies that, just as they take on other healthcare policies, this is something that could be embedded into those policies. And then community organizations. Monica mentioned those trainings. There were several trainings and several ways that this work could be played out through the conversations, but there were different areas of people who needed to be trained. So providers needed some trainings. They needed trainings to better develop their skills to be able to go out to the community, but also community members needed training just to be able to have the conversations with their peer groups. And so we came up with a very long list of training topics that could be used to reach every area of the community. And so I would like to talk just a little bit about how we put these groups together. And so what you see here is a digital graphic recording. We enlisted a colleague, Rio Holiday, to record these sessions. Of course, as we have gone through COVID, we know that our personal interaction is significantly decreased. And so having a focus group on Zoom, almost with such a topic that, really needs a lot of care, we wanted to make sure that we had the right components, the right players to make this a safe space and to make it open for everyone. And so, Monica, as she mentioned, is a mental health professional. And so we knew that this would be a topic that was very sensitive in some areas and would evoke some emotion. And so we wanted to make sure that we had someone to be able to have the conversations and take care of the participants throughout the conversation. But we also wanted to make it welcoming for those to come in and see something. When we're talking, we want to see something. And so the digital graphic recorder, we compartmentalize the conversation in these different sectors, and you've already heard the results. So we talked about caring conversations. That's where our language, the health literacy component, the type of documentation, patient's agency, and the type of settings the conversations were had in. We put that in one bucket, and you can see those conversations and how that happened on the screen. And then the education, we talked about what type of education was needed, the type of legal support that was needed. Participants even noted that there needs to be a directory who works on all of these pieces of this work to get us to this point where we can actually have the conversation and move it forward. And then direct support. And you've heard all of us mention about those advocates and family members. Who's able to provide the direct support? And so that we put that in a bucket. And then the advocacy component. And you can see our conversation, many said we were fighting a monster. And so you can see how that conversation kind of played out. So this was a depiction of our first focus group. And here's a depiction of our second focus group. And just again, speaking to the format and how we put it together, we arranged both in the same way for methodology and consistency, and to make sure that we were gathering the correct conversations. And once we finished these, well, actually periodically during each conversation, we stopped, we let the graphic recorder come on, and everyone had an opportunity to see where we were in the conversation, to also make sure that the conversation was being recorded in a way that was correct and accurate and reflective of not only the words, but the thoughts and the feelings that were coming out of the conversations. And so we thought it was important to just make this note about how we had the conversation, because number one, these are already hard conversations to have. You've seen the data, and to even pull people to a group like this can be challenging. How do we pull people into a focus group to talk about end of life care? Ayanna and her team have a big job. And so as you think about the work that you do and how you talk about health literacy, how you put things into play, and how you create policies and trainings, particularly around end of life care, we encourage you to make sure that you take a lot of time, number one, to get the right language just to have those conversations. And so we spend a lot of time on the background having conversations around the focus group script. How do we have these conversations? How do we bring them up? Will this question evoke emotion? We put in stopping points to see how people were feeling throughout the conversation. So it was almost twofold. We were gaining valuable information from participants, but we were also engaging the conversations right head on. We were also engaged in the conversations from this health literacy standpoint because we didn't know the right words to use. I almost kind of felt like from the beginning, we may have been tiptoeing a little bit around the words until we even got comfortable with what the conversations were supposed to be. And as Monica went through the facilitation for each session, I even picked up on how she used the words that participants used, which was very important in that conversation. And just to make even us as outsiders be a part of the community. And then we recognized that there were so many different subcultures, as Monica mentioned, within each group. It was important to take care of that too. So after each session, we did debrief. We felt like the conversations all went in a great direction and gave End of Life Choices New York a plethora of data and information to begin having these conversations in a very concise and caring and welcoming way. So after all of this, we've talked about the data, talked about how we did this work. There is this conversation around the future of this work, because we often think about end of life care specifically being for one group, and that's an elderly group, which we know to not be true. And as we've lived through COVID and watched things that have gone on with COVID and how, young people, it had no face. And so this encouraged us to look at what the future of this work is and how End of Life New York takes this work and spreads it to a variety of groups. And so one thing is learning from other communities. This group specifically focused on Black New Yorkers, but it even came up many times the LGBT community, Latinx, and Indigenous communities. And so there's opportunity to learn about language to use with those groups and how to provide direct support. And then engage in other communities and areas in the conversation and action around end of life care and planning. So thinking about Black millennials, maternal health, and activism. So these conversations really came about, some of them around, on the heels of George Floyd's death. And so that brought about, activism and how activists do their work. And I can recall a conversation that I just had a couple of weeks ago. An activist in maternal health said, "We just die. Nobody knows why, we just die." And so that goes into being able to take care of ourselves, but also have these conversations around how the work of activism is taxing, and those people should have access to end-of-life care and planning. And then looking at the statistics on maternal health and the inequities in maternal health, and how specifically around Black women, the unsettling reality is that type of planning needs to go in to the maternal care. And then education and partnership. How do we spread this work out to make sure that every sector of the community has an opportunity to reach someone? So community engagement was big. Even in the groups, participants talked about communing with food. That's the big thing. And so engaging community, and then professional development, offering those opportunities for those of us who are working in the end of life care arena to be able to build our skills. And then leaning into new and emerging and existing professions for support in end of life care and planning. So we ended up having grief guides, end of life doula. Those were on the call, which was very interesting because those were roles that, for me, I had not heard of as an end of life doula or a grief guide, and even expanding those roles of chaplains. And how we can really lean into those to really guide people through this work. And as they come upon the end of life planning, supporting their family afterlife. And then more in-depth understanding of the subcultures among Black New Yorkers. And when Monica talked about the language, it depended on what subculture a person identified as to how they wanted to have the conversation, the type of traditions they wanted to use. How do they even include those traditions into this American model or system of care. And so end of life choices believes that no dying person should have to endure more suffering than he or she is willing to bear. Everyone should have the right to die, if possible, in a way that he or she decides and controls, consistent with his or her beliefs and values. And so we know the end of life care is a social justice issue. Access to education and resources, the really exacerbate inequities when there is not access to those education and resources. And then the conversations around end of life care and planning are rare among Black New Yorkers. This provides an opportunity for end of life choices to support providers and communities in better planning, conversations, and advocacy. And so the big thing that we really want to leave with you is that number one, this is a social justice issue. And in having these conversations, we need to make sure that we're using the correct language that is acceptable, and language that really creates a supportive environment for participants.
Thank you, Nikitra. And we do see your questions, and we're going to, at this time, go ahead and try to take as many as we can. So for the first question, thank you, Patricia, for sending this. How do you have this conversation with your white counterparts when they are unable to see or acknowledge there is a difference?
That's a great question, and something we're still working on. But for End of Life Choices New York, we actually launched what we're calling an End of Life Care Community Advocate Training Certificate Program. And so it's a self-paced course for people in the end of life space. And there are modules that talk about disparities in care and disparities in access, and talks about specific populations and their needs. So that's African-American communities, Latinx, LBG, even LGBTQ incarcerated populations as well. And so we're really working hard for the folks in this space to begin to understand the nuances there and dealing with these issues. And we've done a lot of work around educating professionals. We provide CEUs to social workers. We've done a lot of webinars, and we speak at nursing schools, law schools, medical schools to get people early on in their professional development to start thinking differently about these issues.
Thank you. And we got 3 questions about hospice from Marissa, Marion, and Gloria. I'll go ahead and mention all 3 of them, and then we can sort of discuss. Do you feel hospice workers are adequately trained to care for Black patients, such as how to work with Black hair or recognize pressure sores on darker skin? What areas of growth do you see? Another question related to hospice: how can we help patients needing hospice overcome the mistrust of the hospice care team coming into their home? And then another one, let's see here. As hospice is paid at 100% through the Medicare program, what do you believe is the best way to ensure that all people do know they have access to these services? And Ayanna, I know you probably want to take this one away, but I just do want to point out that our work was not focused on hospice per se, but end of life care. So we were just thinking about all people and not necessarily for hospice. But Ayanna, I'll let you address those questions.
Sure, those are huge issues in the hospice system. This wasn't necessarily focused on it. We were just kind of looking at the fact that New York ranks last in hospice utilization as kind of signifying some of the tremendous issues that the state has in addressing end-of-life care needs, and particularly people of color. In regards to hospice, we are working with organizations. There are a lot of organizations working in the space, but we're working on legislation. We have a law called the Palliative Care Information Act, which means the doctors need to tell patients about their availability of palliative care. And we're working on legislation that in terms of hospice, so that people can better understand their hospice rights and be able to utilize them early. But a lot of the problems with hospice access has to do with physicians who don't want to refer their patients, don't understand how hospice works, or even see it as giving up on the patient. And then in terms of kind of the issues of hair and bed sores and other things, there's definitely a lot of training that needs to be done. Even in New York State, hospices aren't required to have interpreters. So that's the legislation that the New York State Hospice and Palliative Care Association is working on. So there's a lot of problems there in terms of access and meeting the needs of a diverse population, considering how diverse New York State is. We still lack a lot of these services and have a long way to go.
Thank you, Ayana. Here's some other questions here. When is an appropriate time to discuss advanced directive in reference to age? Yeah, I'll start with that one.
Just for our organization, even in this conversation that we had in the focus groups, we believe anybody 18 and up should complete a healthcare proxy form. The New York State healthcare proxy form doesn't require a lawyer, it just requires 2 witnesses. The witnesses can be anyone, just not the person who you're designating as your healthcare agent. So have the conversation early. Oftentimes when we go into the hospital or a certain procedures, we ask to fill it out. Certain universities ask students to fill that out. So as soon as possible, just designate the individual because that's of the utmost importance. And then secondly, engage in conversations. And that can be had by watching TV shows, watching all those medical shows on TV or movies, where you just start to talk to loved ones about what they would want in certain circumstances and situations.
Yeah, thanks, Ayana. I'll just add from a mental health professional, or from my point of view here, that death is something that impacts all of us. And, you know, legally, we can't talk about some of these paperworks until a person is of age, legal age, right? But just note that young people definitely think about these things. In fact, one of our participants was very young, maybe in her early 20s, I think. Can't remember her exact age. But, and she was doing the work of helping families talk about grief and death and dying. And so young people are having these conversations, especially right now during COVID. And so it is definitely normal. And I think it should be normalized for us to talk about these things with them when they are old enough to, you know, get the paperwork and things filled out. Here's another question.
Could I just add that, you know, just building on what Monica said, that was a lot of the basis of the conversation as well, to take this conversation away from a certain age group and make sure that we all know, you know, how to have these conversations and how to make them normal conversations and specific to the groups of people. Like we talked about activists, we talked about maternal health, we talked about all these different areas that, you know, where you don't see maybe an older death, but, you know, death is kind of across the spectrum. And so I think that was the root of why we had much of this conversation.
Right, and I just wanted to speak to the younger doula in her 20s. She was doing, she believes in intergenerational conversation. So grandchildren talking to grandparents. And we also started this conversation by highlighting different Black celebrities. And so they died at various points, looking at a Chadwick Boseman or Aretha Franklin and various Kobe Bryant, just various states of the lifespan that individuals were dealing with these end of life issues, oftentimes unexpectedly.
Yes, absolutely. So here's a sort of related question here. Thinking about literacy, so I really like this question from Carol. Was the way legal documents were written a barrier as well?
Well, just speaking from a New York State perspective, the New York State healthcare proxy form is pretty simple, but I mean, there are still some things, nuanced things that are difficult for people to understand. There's a section about organ donation. You essentially, though, are empowering an individual to make a decision for you. And it's less what's written on the paper. And the form is really just names and contact information and signatures. But in terms of living will, that's a far more complicated form. It's not always always acknowledged by hospital systems. And you do sometimes need a lawyer involved, because if this happens, then I want this. If that happens, then I want that. So that definitely is a barrier to that kind of level of descriptive care you want at the end of life. But in terms of just acknowledging the agent, the New York State healthcare proxy form comes in multiple languages, and it's a very simple 2-page form to complete. And just people just don't know about it. And it's available if you Google it, and it comes up. You can print it out pretty easily.
Thank you, Ayana. And I just wanted to point out that we did have at least one participant, right, that predominantly served people who were Caucasian. And even that person talked about that some of these forms can be complicated, and that's why their job exists, to help people navigate completing some of these forms. So it really just depends too where you're living. Like Ayana said, things look different from state to state. So it's not a one process for everybody. I think maybe we could take one more question because it's 3:29. So I'm sorry that we're not getting to all of them. Do you have our contact information to put up, Nikitra? If so, maybe people that we're unable to get to can email us. We would welcome that. But for our last question here, I'll go ahead and take, what do you think are some cultural or spiritual considerations that can be made for palliative care practices? So thank you for that question, Bridget. I'm sorry, Fernando and Brandy, that we didn't get to your questions, but please email them to us.
That one, and actually, I'm not sure of the answer to that, but there is a role of chaplains in palliative care for sure. There was a chaplain who participated in our conversations and talked about the role of spirituality, but to the specifics of that, I can't. I'm not knowledgeable enough to share, but there are a lot of organizations, Chaplains for Change and interfaith councils that kind of explore the role of spirituality and support in palliative care. And I also wanted to, before, in our last seconds here, on our website, we have a lot of educational videos that speak to some of these topics and questions that were brought up. If you go to our End of Life Choices New York YouTube page.